Recording started.
Good afternoon, and thanks for joining us for our January 26th Partner in Care Roundtable, Transgender Health Consumers. I'm Michael Hager. I'm the Manager of Technical Assistance and Dissemination at the National Quality Center, and I'm really excited to bring this program to you today with all of our community presenters and our faculty. Please bear with me. I'm feeling a little bit under the weather today, so if I say anything unclearly, just ask a question and I'll be happy to reiterate. And thanks very much for your patience with me. As I mentioned before the webinar began, I would never dream of calling out sick for such an important discussion as we have in store for you today. So before we start, we have a number of people on the line. You'll note that everyone's muted. We did that so that we can avoid having any unwanted distractions. Our presenters are unmuted. I have Dolores, Tio, and Cecilia unmuted, and we'll be hearing from all of them as we work our way through, and they'll be able to make comments as we're presenting and interact with each other. If there's any point in time that you want to unmute your line, all you need to do is click that little orange button to the right of your name, and you'll be unmuted and able to speak. We ask that you remute your line afterwards. So instead of everyone introducing themselves out loud, if we could just put a little information about ourselves in the chat room. I've seen a bunch of people doing that, so let me go ahead and throw my hat in that race. Michael Hager, NQC, New York, New York, and disparities lead. Great. And while we have our friends typing into the chat room, we ask that you engage with each other by entering questions, comments, concerns, reactions into the chat room. Again, that invitation to unmute your line, I think that we're small enough that that's fine, but we're big enough that we want to keep everyone muted, if that makes sense. A lot of us have some groovy on-hold music. We ask that you avoid putting us on hold at any time, even if you are muted in the webinar, just in case something happens, and it's just very distracting for folks who are trying to listen in. These webinars are all recorded, and we save them on our website. If you go to endisparitiesexchange.org, one of the top links that you'll see there is review, and you'll see the full list of all of our webinars, office hours, and Partners in Care Roundtable recordings and slides that we've had to date. At this time, I'd like to turn it over to my director, Clemens Steinbach, who is instrumental in everything that we do at NQC and in helping to design and plan for this learning exchange that we're all participating in today. So, Clemens, words of welcome. And that is strange. I'm not seeing my boss on the list here. So on behalf of Clemens, a warm welcome to all of you. This is a very important initiative for many reasons, and we're very excited to be working with you to make sure that all people living with HIV can experience the same high-quality care and achieve the same outcomes. And your commitment to serving everyone equally is very much appreciated, and we're really excited to work forward as a team on this initiative. So hope I did well by my boss there. For those of you who are less familiar, the End Disparities Learning Exchange is a 9-month initiative that promotes the application of improvement interventions to reduce HIV-related disparities in 4 key populations. We're trying to create a community of learners among all of you, the Ryan-White HIV/AIDS program community, regardless of part funding, so that you can share experience and get to know each other a little bit. And we also have experiences like today's Partners in Care Roundtable, which is really an opportunity for consumers to come to the table and to talk about issues that affect them as it relates to ending disparities. And we're really excited to have some big consumer voices on the phone today sharing their perspective. NQC is a large program that has many moving parts, and this is just one of them. For more information on the National Quality Center, you can go to nationalqualitycenter.org. And since we got a little bit of a late start, I don't want to spend time taking away from our wonderful agenda, which includes welcome and introductions. Those are underway. I see folks chatting in the chat room. We're going to hear our stories about transgender health, and we'll hear from Cecilia and Tio and have an opportunity for folks who are trans on the line to share their stories, or if there are any stories about transgender health that you'd like to share, I think that that would be really wonderful, just to kind of think about this issue from a consumer's perspective and to help drive progress and change. We'll hear about some of the special projects of national significance that Cecilia's been working on, and it's a great way to understand that you know, this community is an important community as far as the work of our federal partners over time, and we just want to make sure that everyone's aware of all the wonderful things that have been happening in that area. And then really importantly, we hear over and over and over again, one of the best ways to make sure that we can help to put an end to disparities is to make sure that we promote leadership among groups that are experiencing disparities. So how do we build leadership capacity among trans people living with HIV?
So our learning objectives, I hope you can all hear me. My name is Dolores Dockery. Today we'll focus on again, as Michael mentioned, we're going to talk about one project of national significance that focuses on transgender health and kind of summarize some of the activities. We're going to describe 2 ways leadership skill can be built within the transgender people living with HIV community. And our first presenter is Cecilia.
Hi, good afternoon, everyone. Thank you for joining us. My name is Cecilia Chung, and I am the Senior Strategist at the Transgender Law Center. And a few years ago, I also have founded a new project called Positively Trans, and it is a project that organizes and mobilizes transgender people living with HIV and form our own network of transgender people living with HIV, and the goal is to fill the leadership gap within the trans community and in the HIV community, and also really have a more organized way for us to tell our stories and to do more community led advocacy that's evidence-based. Instead of hearing my story, I actually would like to yield the time to Theo first, for him to have a chance to tell his experience as a consumer, some of his challenges that he has faced, and how he overcame some of those challenges. And then we'll come back and talk about how other voices how we're trying to bring other voices, to all the work that we do. And so after that, I think we can show you a couple of video clips of the digital stories that, our Positively Trans member have made. And, at the meantime, I'm going to forward those to Michael so he can take a look at them first.
Fabulous.
Is that all right?
Fabulous, absolutely. Thank you so much, Cecilia, and thanks, Theo.
All right. Thanks, Cecilia and Michael. I think, my access to care has, as a trans person, I was diagnosed with HIV in 1995 and with AIDS in 2000. And as I said in the last call, when I was diagnosed in 95, I had yet to begin gender transition, so the world was reading me in a very particular way, and mostly as a butch dyke was sort of the community I walked in and the identity that I found some shelter in. And at that time, certainly in 94, 95, we were actively being told as a community that we weren't at risk, right? And there was a lot of misinformation. I had to fight. I had to fight to get tested. And that's sort of been an overarching theme around sort of my experience in general, which is consistently having to prove who I am and my life experiences. it's not uncommon, I think, largely for trans folks, particularly, I think, for trans men and trans masculine folks and non-binary folks, to have to actually, both educate, but also like this assumption that we don't even exist. Obviously you can see my image, you can see who the doctors see when I walk into the clinic or into the ER, and there's a whole host of assumptions that folks make about that. And my experiences have been that because of who I am and what I look like, that people do not expect me to have been raised a girl. They don't expect me. They aren't prepared. They aren't prepared to give me accurate information about my body, my health risks, and those kinds of things. And I think that's true for particularly a lot of trans men. I think trans women face a different uphill battle in that way. And I think, and again, like everybody else has said, I apologize for having been sick for the last few days, so I'm going to work through being a little fuzzy myself. But the thing I think I want people to really kind of understand is that I don't really feel like, for me, that the burden should be on me to prepare a provider or a site for my arrival, right? Like, this is, we're in 2017 now. And so I think all of that groundwork should be laid, and it should be laid in such a way that, regardless of the constellation of identities you bring, I happen to be a working class, white, queer, trans man. And so, I have to also be partnered with a genderqueer boy who was assigned female at birth and doesn't identify as male. And so I should just be able to walk in and get health care, and as Cecilia said, I have to have really good care in terms of my primary care and my infectious disease care right now. But I don't always expect that. And one of the things that I think people need to understand is that it's not simply our infectious disease clinics that or I have a relationship with my infectious disease doc, right? I have that's stretched on now for 15 or 20 years. I have a relationship with my primary care provider, again, 15 years or so. But I don't have any relationship with the ER, right? And that's where trouble really often begins, and Cecilia certainly knows this, that and that the sort of complexity of living with HIV, particularly being a long-term survivor, and also being a trans person, and all of the ways in which we end up sort of at risk and left without services. And so, a year ago I had surgery, and it's just sort of an ongoing, complicated process. And I was having complications, right? So I walked into the ER looking for help, and they were, because when I was dressed, I looked a very particular way. And I was trying to explain what the issue was. And the minute it became very clear that this was about being trans, and about my anatomy that was sort of unexpected, everything broke down. And nobody would look me in the eye. I was sort of, and I'm old enough, and I have enough sort of stubbornness, I think, at this point in my time, that I wasn't going to let someone touch me if they couldn't look me in the eye. And so, I think I'm going to go somewhere else. But I wanted the physician's name in order to make sure that this never happened to another human being. And when he refused to give it, they called security, and these big guys showed up. And I'm really clear that this is the moments where my whiteness really protects me, right? Like, I'm a small guy. I'm 5'6", not terribly threatening, as a small person. And here were these four big men, surrounding me. And that's really important to understand, is that to understand how quickly environments and systems and institutions become violent, really, right? Aggressive and violent And what they're reacting to is their own ill-preparedness and their own shame, right? But they don't have a way to actually do that, and it gets laid at our feet, right? So all the ways in which when our systems and our institutions fail, very rarely is there a system in place for kind of humility to be like, whoa, like we didn't see that coming and we weren't prepared and we should have been and we're so sorry. Right? That's all like people need. And I think it's really important to actually not only do this work, but to really understand that all through this, there needs to be this sort of understanding about cultural humility and this sort of level of, we're going to, people are going to screw up, but what are the mechanisms in place to actually center, like that wasn't my first rodeo, right? It wasn't the first time I had been harmed in a medical setting. And so understanding that I'm coming in already expecting to be mistreated, right? So it's like, how do we understand the fact that we're working with people who are coming in, with an amazing ability to get their needs met in a system that's hostile and ill-prepared, and yet the burden just sort of is magnified. And I think it's one of the things that to be mindful of in terms of looking at all the systems and all the points of interaction and contact that trans folks have, and to really broaden that out. I mean, somebody in the last call talked about making sure that security was trained, right? But it's, again, and every single thing we do needs to be from a lens of trauma sensitivity, right? Like, to be really aware of what folks who have experienced an immense amount of trauma and an immense amount of trauma in an ongoing hostile system. I mean, individual people can mean really well, but the overarching system remains hostile. And so it's like, oh, well, of course this person's like irate and won't settle down, right? Because that's what trauma looks like. And understanding that also it's not a one-to-one transaction. So you might have gotten like all your stuff together, right? You might have done all the trainings. You're like all teed up to go and are doing the right thing. And I'm still probably not going to trust you. Like I might be like, but I'm probably not going to trust you. Like you're doing the work so that by the time I meet the third provider who's done that work, my nervous system will settle, because that's sort of what a lifetime of trauma will do, is it takes repeated experiences of down-regulating for me to be like, oh, okay, like now I finally get it. And so to not feel like, you haven't been of service when it's not a one-to-one transaction, like when it doesn't work the first time off, I think is really important to remember. And so I think that's those are the things that are really present for me today. So, and certainly questions as we go.
Great. Thank you so much for sharing your story, Tio. It's really compelling, and there are so many things to pick up on in your story in terms of dignity and being welcoming and being patient, for people to experience their trauma and to come to the point where they can trust you. I'm wondering if there are any resources that you found helpful in terms of training and in terms of helping helping provider organizations build that framework that you were talking about. That's really their own responsibility. I picked up on it's not the responsibility of patients to be educating their providers and bringing them into 2017. So are there any frameworks or training resources that you would recommend folks look into?
I mean, I think we can probably provide like a long list. The one thing I would say is that there's a lot of trans folks who are really, really skilled. I happen to do faith-based work, and so I happen to go into faith communities and work with them around welcome. And we actually do things like, there's faith communities that will actually have like, secret shoppers, and so you'll send people in to see what that experience is like, right? Like as a way of actually honestly evaluating whether the mechanisms are working. And there are trans folks, particularly trans folks of color, who are incredibly skilled in doing this work, and they need to be paid, right? A lot of times our invitations are to come in to talk about our lives and our experiences and offer our expertise without being paid a consultant's wage, right? And so the thing I would say is, and we can probably find a list or to make requests for them, in each region in this country there is an incredibly qualified, at least one, probably several qualified trans folks who are either medical professionals themselves, you know, or do this for a living, who can come in and do a full systems evaluation. And it's not enough to do like a panel, right? It's not enough to just hear people's stories. You need somebody who's really skilled in the ways that medical systems work. Like because I grew up in a nursing family and I worked in institutional psych for years, I understand like charting, right? I understand medical documentation and the difference between insurance and charting. And I also, because I live on the other side of that, know how to get around those systems, right? And I think you need folks who understand how the systems work, understand the need from the community, and who can creatively help bridge those, but with always care and dignity of the consumer at the heart of that, right?
Yeah.
So, and we can certainly help you find lists of folks and create a list.
That's beautiful, and I love the way it all kind of ties together with you know, the messages, that it's really important to build this leadership within the community too, and this leadership is self-sustaining and will help to, you know, make sure that everyone understands, you know, to the extent they can, you know, like how to provide the best possible care. You know, and I'm wondering if we can take trans folks' leadership, train our HIV centers, which is likely to be a very high compassion point within a health center. You know, I'm looking at Chris Scope's comment here from the Medical University of South Carolina in Charleston. You know, as individuals who are woke in this way, how do we help the emergency department? How do we help the highest levels of the hospital, you know, administration understand this too and value this and help to spread and disseminate some of this education that we ourselves, you know, will have through that process of awakening?
Right.
Cool. All right. Does anyone have any questions for Tio, or are we ready to talk to Cecilia and hear a little bit of her story? All right. Well, thanks, Tio. Cecilia, I think you're up.
So is my video on?
It's not.
I'm not sure. It's not. So should I? Well, actually, it's a little dark, so maybe I don't need the video. So
it is perfectly fine.
Yes, I feel bad that everybody else has their video on. Okay, let's just do it. Hold on one second. So, and thank you again, Michael, for inviting us to be part of this webinar. And I sent you a couple of messages earlier. One was 2 links to the videos of stories that I would like you to share, and also a PowerPoint that we'd like you to share with, you know, like the audiences after the webinar. So we're not going to focus on the actual PowerPoint because it's more about the project itself. So let me go back a little to talk about my own experience, and my experience is a San Francisco experience, so please bear that in mind. Although we have a lot of advances, but in terms of like transgender care or looking at transgender care as part of primary care, it's still, you know, like an evolving process, and not every state have come on board, and so that's where some of the disparities lie. I was lucky enough to receive my care in San Francisco when Tom Waddell Health Center launched their transgender clinic. And so for me, it was really one of my health priority. Wasn't so much about my health itself, because when I tested HIV positive and when I found that out, there was no known medication, you know, that is distributed, you know, to all the patients. You know, there are trials and there are what they call salvage therapy at the time. That's when, you know, people get really sick and, you know, and whatever they call the frontline therapy had failed them. And at my time, you know, the first line therapy was ACT, and which later on, of course, you know, we know that the dosing wasn't correct. And so the reason why I went to like the clinic is really to access hormones and, really to find out what options there are for me, like in terms of my journey of transitioning. And so, of course, there are a lot of other barriers, and at that time, we were still going by the old Harry Benjamin standard of care, so I had to have a therapist, I have to have, providers, and I have to be seen for a certain period of time before I could actually access, surgery. So there's a lot of hoops to jump through. On top of that, those surgical options were not covered by health insurance at all. So even if I have health insurance, that wouldn't be an option. I still have to pay out of pocket, and usually, that cost is anywhere from $15,000 to like $30,000. And for trans men, the cost could be even higher when you consider both top surgery and also the alloplasty or or whatever bottom surgery that they choose. In addition to hysterectomy, a lot of times insurance back then refused to cover most of these. They would say that this is transition-related care, and they have some exclusionary languages in there, to prevent people to access the care they need. And that's what happened to me. So, when I was accessing Ryan White care, pretty much, the only thing that I had access to was prescriptions to estrogen. But at the time, we really didn't have a lot of discussions around drug interaction. So when the first protease inhibitors came out, the first line of protease inhibitors came out, it took me 6 months to realize that my protease inhibitors that I was taking at the time actually increased my serum level of estrogen, which caused me to become really sick, and my prolactin level is high. Of course, the doctors would know more about prolactin levels. I didn't know anything about that. And so it becomes really important for me to have a doctor that understands, how to monitor, my estrogen levels, and to make sure that it's not interacting with other medications. I think that one good thing about the digital, digitizing and really having so much technology on our side is that today, if you go to a pharmacy, they would be able to actually flag, those that have potential adverse reactions or drug interactions. So, we don't have to go through the same thing. So, needless to say, when I first accessed these services, AOL just came online. So, so we have come a long way since then. And so that's really one of the really important points is that, to find a pharmacy that is, welcoming to the trans community, and so the patient would feel comfortable enough, to really go to that same pharmacy for all their prescription, because this way, it will be much easier for the pharmacy to flag any potential adverse effects, side effects, or drug interactions, that we have. And second, of course, to get to there, you have to have a culturally sensitive or culturally competent provider. What we have found out, through our needs assessment is that a lot of times, transgender patients would choose not to return to the same provider if they feel that the provider is hostile or neutral, and they would feel very uncomfortable to go back and, give them so much of their personal history. I think that provider-patient relationship is one of those relationships that can make somebody feel extremely vulnerable because, there's so many things that you have to screen. So it's really important to really be mindful of that. And sometimes it's not the provider itself. It could be just other staff in agency. For instance, if the reception didn't know to pay attention, to know that you may be going by a different name and call you by your name assigned at birth, that some folks would feel very uncomfortable and feel offended, and they might not even get to see the providers. And it's very common in the trans community to have these experiences. And more importantly, because of the way that our healthcare system is set up, most patients don't really have enough time to bond with their providers. And I think that it's really important to feel comfortable enough with the provider, to share with them every single details of our, lives that potentially affect our health and our journey in transition. And our network of transgender leaders living with HIV, that they would have a chance to tell their story, what it's like for them, and so that more folks like providers and advocates and other people in the community get to see them as a human being and not just somebody who's coming in for medication. And I want to share two of these stories. One done by Teo, and the other is one of our Positively Trans members from New York. And after we share those two stories, I'll come back and talk about a couple of the projects that we're currently involved with. Is that okay, Michael?
Absolutely. So I've queued up these two videos, and we're going to see Octavia first, right? Or Teo? Okay. All right. So my solution is kind of, since I don't have speakers, is to try doing this. So I'm going to take off my headphone and put the voice here.
Before relocating to New York City, all I knew was drugs, partying, sex, and debt. You see, Ethan, in the South, there were not many advancement opportunities for people like myself. It was hard to live in my authentic truth as Octavia. I had to resort to maintain.
Oh, crap.
I could not access quality yet healthcare, nor the basic necessities afforded to everyone else. Therefore, I packed 5 suitcases and purchased a one-way ticket to New York City, where I began to live in my truth unapologetically for the first time. I was no longer afraid of what others thought of me, because their opinions were not mine to carry. I would no longer be held hostage by society's should, could, and would have, because I define who I am. It took losing everything which I held near and dear in order to gain everything which has now made my life worthwhile. My greatest accomplishment in life was becoming your mother. I left everything behind that was near and dear to me in order for me to get to where I am today. I never knew I could become an activist, advocate, mother, scholar, and wife. You are loved beyond measure. In this life, you will experience the biases, ism, ageism, colorism, sexism, etc. However, you will have been enlightened on what it is to meet people where they are. You will be able to understand what you can handle and hold and what to release. You are gifted, smart, and talented, and have what you need to be the catalyst of change in which I envision you to be. My gift to you is knowledge of acceptance and the ability to become an agent of change. You, my child, are the greatest gift bestowed upon me.
was an incredible story. Thanks so much for sharing that. And I just wanted to make sure, could everyone hear that okay, since I had my weird workaround going?
There was a bit of crackling on the line, but eventually it came out clear enough.
Okay. Let's start this one to get a sense of some more stories, and then we can talk a little bit more about the resources available through Positively Trans, because as a spoiler, we have one of Cecilia and Tio's friends and colleagues, Ariana Lind, presenting with us in 2 months, our focus on African-American Latina women. And she's embedded in communities in the south of Florida. As Tio was saying, many communities actually already have experts, within them who are part of that community, and Positively Trans helps to connect folks together. So let's hear a little bit more of this next story.
I was born the oldest daughter in an Italian working-class family. And I grew up at a time where I didn't know that queer folks existed, and I certainly didn't know that trans folks existed. What I knew to be true was that I was a boy, and it didn't matter what the world told me. I just knew that to be true. But I also knew that if I spoke that out loud, that I would be ridiculed, that it would be taken from me. My parents are wonderful people, and I know without a doubt that they love me. But when I was a kid, they were still living in their demons and their addiction. And so I grew up with violence, and I grew up being hit. And I grew up understanding that love and violence could coexist. And it wasn't long before the world started to tell me out loud that I didn't have a right to exist, that what I knew about myself couldn't possibly be true. It happened at 16 when I went to see a priest because I was struggling with my gender and my sexuality. And I told him that I didn't know if I could survive if God didn't love me and if I would go to hell. And he looked at me with a pained expression and told me that he couldn't tell me that I would be okay. He couldn't tell me that God would love someone like me. And for the psychiatrist, when I was locked up after a suicide attempt, who told me when I said that I really thought I was a boy, who told me that of course I'd want to be a boy, who wouldn't? And so I stopped talking. By 17, I was drinking, and I wasn't drinking to get a buzz. I wasn't drinking to feel good. I was drinking to die. I was seeking my own annihilation. And so it's no wonder when I found myself in an abusive relationship with someone with HIV that I couldn't see myself in the future. So I chose whatever was going to get me through the day, whatever was going to keep peace, whatever was not going to get me hit. So when I started to have symptoms and I showed up to get tested, I was told I couldn't possibly have HIV, that people like me, we didn't get HIV. And so I had to fight to get tested. And when the test came back positive, I was told I must have lied. By the age of 35 in 2002, I had 33 T cells and a viral load that was off the charts. I wasn't going to make it to 40. And so I decided for once that I was going to stand up and live in my authenticity, and that I would be damned if I was going to die a girl. And so I chose to transition because I didn't think I'd be here for the consequences. But lo and behold, as the months went by, and I started to look more like a boy and then more like a man, I started to like myself. I suddenly felt like I could live in a world and grow to be an old man. So I started to fight. I found medications that worked, and my health got better. But still, 21 years later, living with AIDS isn't easy. Being a trans man with AIDS isn't easy. The world still tells me that I shouldn't exist. But I'm still here. And for as long as I'm here, I get to spend my days being a living invitation to hope, that I do exist, that I have a right to exist, that each of us, as trans folks, have a right to be here.
Absolutely amazing. Absolutely amazing.
Wonderful.
So some folks have asked in the chat room if I could include the links. So absolutely. As always, these chat room transcripts are going to be shared with everyone who dialed in today. So you can save these now, or you can just wait for the Word document to come at the end of the presentation. So Cecilia, maybe you could talk a little bit about you know, some of the other types of stories folks could find in case they're curious looking themselves, and then we can have a conversation about some of the trans-focused special projects of national significance.
Okay, so thanks, Michael. We have so far done 15 to 16 stories. The first digital story workshop was held at the beginning of last year in Atlanta, and we had really been trying to focus on trans women of color living with HIV. Although this is kind of it seems very typical in our work, is that once we start doing work for trans women, the trans men start to pop up, and we're really trying to do what we can to be inclusive. And so Teo and another new member just joined us, who is from the DC area. And later on, towards the end of this year, we're going to do a digital story workshop specifically for trans men living with HIV.
Awesome.
I want to just throw it out there because we are working with Teo and our other member to look at organizing trans men living with HIV to create a space so they can discuss, their issues openly, and also, really provide the support for one another. And Teo has started a secret group on Facebook. So if you're a provider and you have trans men as your patients, and you want to and if they are feeling comfortable to be introduced to other trans men living with HIV, Teo will be the person you can reach out to, because I want to honor their confidentiality as well. So and to really create to be really mindful in creating a space specific for them, and they can have discussions. And then when the time comes for the digital stories, we're going to see who's interested, and we are going to have a cohort of 6 participants for the digital stories workshop, and we're going to fly them to Berkeley, where the Story Center is, to have a 4-day workshops and, retreats, about, reflecting on the journey to see which part of the stories they like to tell. So that's how these stories were developed. They really get to really look at, some of them told the entire spectrum of the story, from when they got HIV and to what their attitude is today, when dealing with HIV. And also there are stories of success. One of the well-known leaders in the community is Didi Chambly from Atlanta, and she did a stories about her journey from being homeless to now, a leader in the community, and what that's like, and to be able to reflect back and to see the kind of journey that she went through to get to where she is today is really powerful as well. So I encourage you all to check these stories out. And we are also really happy to come to you to do presentations to your trans community, your trans patients. in+care about the data that we have. It is a community participatory research with the goal of sharing these research with the community itself, and so they can use these as part of their resources when they organize and do their own advocacy work. And that's actually the reason why I'm currently in Detroit, Michigan, and we are going to do a needs assessment specifically for Michigan and for Michigan focusing on Detroit, and also create digital stories to talk about what it's like to be in a state and a city where HIV resources are not as abundant as some of the other cities like San Francisco or New York.
So we're running short on time here. I'd love to just kind of I heard several amazing opportunities for both providers and consumers to advance this. Cecilia is such a light for our community, and Positively Trans is one of the major solutions we can consider moving forward. Positively Trans has a number of different videos that you can use in conversation at staff meetings or in other ways to just kind of get people thinking about human beings and the human experience as it relates to the trans community, to start a dialogue. That is a great starting point. Another thing is that Positively Trans folks can come and talk and provide an in-service, it sounds like, to your staff, and importantly, simultaneously to your patients, and to make sure that the trans community within your area understands that they're part of a big family, and they're supported, and they're loved, and there are opportunities for them to take their own advocacy and their own journey to the next level if they're ready and interested in doing that, which I'm sure that there will be plenty of folks who are ready and raring, to do just that. And then lastly, there are, through this, what we're doing, or what Cecilia is doing, is offering leadership opportunities to help lift people up. Speaking from personal experience, as a gay man living with HIV, in working with other folks living with HIV, particularly other gay men living with HIV here in New York, it's very empowering, and it makes me feel really good. It makes me want to take better care of my own health, and it makes me want to take care of more and more and more of my brothers and sisters out there, because I can see how that love and how that connection really makes a difference in people's lives. So I don't know, Cecilia, if there's anything specific about special projects of national significance that you want to talk about before we end with a discussion of other ways to enhance leadership capacity within the trans community.
Yeah. So 2 things to look out for, in the upcoming years. We just partnered with in+care, on the new project for building leadership of color living with HIV, and there we are going to do 3 national training specifically for transgender women of color living with HIV, and the first one will be in this March, and then in the next 2 subsequent years we will be doing 2 more. And the other things about the national project of special project of national significance is that they are actually wrapping up the retention and care for transgender women of color living with HIV, and so we will have more data coming out next year, as well as some specific evidence-based clinic models that you all can consider as adopting, and because they actually have quite a bit of data to share by next year. So please be on the lookout for that. And as Michael mentioned, we are here to help and to really support, trans women of color living with HIV to empower them, to lead, to advocate, and also to really tell their stories and to really have a transformative way of building this movement. So I'm going to turn this back to Michael. I know that we're short of time. I apologize. I tend to get a little bit wordy at times.
No, there's so much good news and there's so much hope to share. And I think that is one of the overarching themes that I take away from our conversation today, is that a lot of times we feel stuck either as a consumer or as a provider who cares about this, this population and about making sure that we achieve health equity for all. And what do I do next? And so I love that this discussion today has provided a number of opportunities for people to think about or pursue. Pick up the phone and call Cecilia, or call Tio or anyone at Positively Trans to think about this. I'm wondering, if possible, Cecilia and Tio, if you could just share your email. I think especially for Tio's case, you know, in terms of thinking about trans men and that secret group. You know, secret groups are a very powerful way to make sure that people feel part of something, but also protected, you know, so that they're not having everything out on the wall or in the community that's searchable.
Are we going into our question and answer session? Do we
have time? Yes, ma'am. I think we have time.
So I've reviewed the chat box, and I haven't seen any specific questions. A lot of wonderful comments are there about the presentation. And I would like to open the lines and give participants on the call an opportunity to ask any questions of our presenter that you would like to put forward at this time. You can also write your questions in the chat box.
Sarah, you do a lot of work with SPINS as well, and I see you making some comments within the chat room. I don't know if there's anything that you'd like to add about SPINS work and other work that you've been doing with the trans community as well, impact marketing. And I think you're muted. Let's see, Sarah can, there you go.
Can you hear me now?
Hello.
There's, yeah, on the Hope to Have newsletter page, there's a trans health document, including newsletter, including resources that might be useful for folks on the call. And it really outlines both some more basic things in terms of cultural competency and is a good sort of primer for folks who are kind of lesser familiar with this topic or looking for resources. There is the Transgender Women of Health, or Transgender Women of Color, rather, SPINS project that is, they're collecting all of the final research right now, and those findings and best practices will be coming out this summer into the fall. But I actually had a question. I was just curious, both to Celia and Tio, what is the #1 mistake that you see straight allies make, and what recommendations would you give to them?
Good question.
Okay, so I think, thank you for asking that question, Sarah. I think that it's a little bit complicated because I think we all come in with different assumptions of the people that we work with. A lot of times it's because of the perception. I think, you know, especially for the trans community, really to be mindful that people are at different point of the journey. So some people, when you first met them, they might have just started and make that, you know, like decision to transition, and which means that, you know, like their driver's license might be, you know, with a different names, their gender presentations might not be congruent with, you know, how they are identifying. So to really be welcoming means that, you know, like instead of assuming that we know the gender pronouns that they use or the name they prefer, we make sure that we ask everybody those questions, because, you know, like you never know who's sitting in front of you who's been thinking about transitioning for a long time or where they are in terms of the transition. And I think another really important point is that not every single trans person or gender nonconforming person think about surgical options, and so some do and some don't. And so I think that it's really important for, for providers to really be mindful and not thinking that everyone that they see have to be on hormones, and also, connect them with the surgeons, so I think client-centered is the key phrase I would use here, because our journey is so different, and our decisions also would reflect these differences.
Thank you, Cecilia. In fact, Lori had a question in the chat box, which is pretty much related to the response you just gave, and she was asking, what do you see as the first 3 concrete steps that an agency should take to become more client-centered around providing services to the trans population?
I think
I think the 3 things, I would let Theo answer that because his stories kind of relate to a lot of that. And Theo?
Part of it is, and I just also, often when I do trainings, I let people know that I would like to reserve the right to tweak their language if it was language that, had I heard out in service, it would have been hard for me. Really beginning to understand the difference between sexuality and gender. There's a lot of trans folks who actually identify as straight, right? So I happen to identify as queer, which has nothing to do sort of with my gender, which I see as a man, right? So cisgender would be the word I would ask, is what can cisgender folks do to be in solidarity? And my answer to that would be sort of, I tend to be far more global than practical, but is to figure out to neither treat us with pity or as heroes, right? Like to understand that we are human beings that have immense amounts of strength and immense amount of woundedness, and to let them coexist and figure out how to support and balance those with us is a big part of the answer. In terms of 3 concrete solutions, we're talking about sort of a system, right? We're talking about who has power and who doesn't have power, and so a lot of times the steps that institutions take are ameliorative, which is their band-aids, right? They bring advisory boards on, but they don't give advisory boards power. And so really figuring out, how to, one is that folks have to be safe, like as Cecilia's kind of putting into the chat bar, right? Like, if I'm not safe entering the building, if the facilities in the building aren't welcoming, like if I walk into a building and there's not a gender neutral bathroom, chances are there's nothing else you can do that is going to prove to me that you even envisioned that my boyfriend can come in and be safe, right? If a trans woman walking into the women's room is going to get harassed, then there's nothing else you can do that is going to tell me, right? So if you're really thinking about facilities and about safety and about all the ways that folks with trauma can land, and the visual cues, all the visual cues that we look for that are like, oh, okay, I can give this place a chance, are huge. So really taking a look at that, taking a look at what facilities look like, taking a look at forms, taking a look at, if I identified neither as a man and a woman, would this form work for me? And really thinking about all the nitty-gritty stuff that come before our interactions with providers is huge. What's your grievance policy look like? Is there an actual way when things go wrong for folks to say, hey, this really sucked for me, and I'd like to help you fix this? And is the institution going to meet that with, ooh, yeah, you're right, we could have done better? Or is it going to be met with this wall of resistance? Those are the big things about, are folks really willing to give up some power? And our addiction to competence, are we really willing to have things change and hear that things aren't going well? I think is really powerful. But I do think, and who we hire, making sure that trans folks are actually hired and are hired above entry-level positions. So, it's really easy to see trans folks on the front lines in needle exchange vans, but you're not going to see them above, sort of in managerial levels. And so really being mindful of who's there and the full diversity of sort of who's there. So, again, not just like trans men, in those positions either. I think there's some really big steps that I can take in training, like ongoing relationships that are like 18 months long, 24 months long, where somebody comes in and reevaluates your progress over and over again. I think they're really powerful.
Thank you so much, Tia. Michael?
Yeah, so there's one more question in the chat room that I don't think that we'll have much time to answer, but it's an interesting one because it touches on an issue that both Tia and Cecilia had mentioned. Hi, I had a quick question. What, if any, would be a suggestion to promote change of forms at the administrative level that would be more inclusive of trans individuals at clinics and individuals' preferred names, for an example? The organization that I work for health insurance reasons, we're told, trans is not identified when a person registered or enrolls in our program, so it's just left off. So I don't know, Tio, if this speaks to kind of the issue you were talking about, that like hiding behind some administrative thing, like, oh, it's too hard because like this one insurance company won't want it, and how do we work around that way? And are there any links or any groups that have been working toward more inclusive administration and forms, and what do you tell the health insurance company that doesn't want to play ball?
It's so funny that we make this out to be rocket science, and it's not, right? Like, I tell people all the time, like, I can go into, my full legal name at this point is Teodoro, right? It's Teodoro Antonio Drake. That's my full name. I go into my doctor's office, and they greet me as Teo. It's not my full legal name, right? Teodoro is my full legal name. That's what the insurance company requires them to submit on a bill, but they don't ever call me Teodoro because they know, right? How many times we have Williams who go by Bill or Billy, or Will, like, and we don't lose our minds over these things. But suddenly, if it's like trans-related, we lose our minds, and so, yeah, there's a lot of ways to do that. There's a lot of ways to make sure that the interfacing paperwork is stuff that you can then distill and send to the insurance company. Every time I go into the doctor, I have to fill out those 5 freaking sheets of paper that ask me everything about me. And, there's no reason why things can't be fill in the blank instead of check boxes or, check all that apply. There's Planned Parenthood in New Haven. I worked with them a while ago to start doing hormone replacement with trans folks. And they figured it out. They figured out that they have, their intake sheets look a very particular way, and then someone has to then put it into insurance language, right? But the client doesn't have to see that, right? And so, for example, sex assigned at birth and current gender is one way. But really check all that apply, right? So I identify as a man right now, but I understand that for statistics and for visibility of trans folks, I really need to make myself visible as a trans man. It's not my preference. I would prefer to go in and check male. But I do check male and then F to M when I'm allowed, right? Because I really understand that visibility is important. So, thinking about that, like for non-binary folks, is there stuff that is beyond man and woman? And there's a lot of ways to do it. Like I think even Cecilia can probably share the ways in which we allow people to identify with us for our survey. But there's a lot of medical providers who are doing this well.
Wonderful. Cecilia, thoughts?
I think that there are a few things here that we really need to talk about. One is, depends on the providers, which state they're in, and whether it is, a state that has embraced the Affordable Care Act or a state that has not embraced Affordable Care Act. Because in Affordable Care Act, there are specific languages that pertain to, non-discrimination of, transgender patients. So it's not really a matter of whether the insurance company wants to collect those information. but, you know, like it is a mandate from the Affordable Care Act that they have to have like meaningful use of the data that they collect, you know, through electronic health records. And so we are really looking at that as, you know, one of the first steps, you know, toward more LGBT inclusive care, that that surveys or intake forms, we start asking questions such as gender identity and sexual orientation, which a lot of times, as you all mentioned, that, you know, they are not necessarily mentioned or being honored. Also, you know, like another go around, you know, with the name is that, you know, a lot of other intake, they also, you know, in addition to your legal name, they will ask you if you have other aliases or, you know, nicknames. You know, that's one way to really capture the names that, you know, the patients really want to use. And I think that, you know, it doesn't really make a lot of sense that why insurance company would have an issue on that, because I thought that, you know, like they really look at the actual insurance number, you know, or the patient number, you know, and get all those information from that they need. So if they don't need the transgender part of the information, they just don't use it. That shouldn't prevent, you know, like providers and clinics, you know, like to add a couple of fields to the forms. And other things that it's really important to know that it's not just Affordable Care Act that is changing these practices. You know, for hospitals who are receiving Medicaid and Medicare dollars, who are accredited by the Joint Commission, they actually also have a field guide that they can follow. If you go to the Joint Commission website, you know, there is the Joint Commission LGBT field guide that, you know, that really like lists recommendations on how to become more inclusive of LGBT patients, including like visiting rights, you know, in hospitals. And, you know, and it's really important to know these because, you know, the next round of hospitals accreditation, those will be part of, you know, like the questions they're going to ask. And so you know, and so I think that that's a lot of reasons why that, you know, the more they can educate themselves on these issues. And I also shared with Michael the Center of Excellence of Transgender Health, you know, that is over at UCSF, and they have a lot of the information that you're looking for. I told Teo, you know, like that the three important things to remember is be welcoming, be safe, and be patient-centered. So, you know, like by, you know, creating these like cues of like a welcoming environment, a lot of times, you know, some clinics celebrate different diversity and, you know, cultural history, like Latino Month or Black History Month, you know, like maybe you can also incorporate, you know, like some other celebrations such as, you know, like Transgender Day of Visibility, or, you know, like, or to have a candlelight vigil for the Transgender Day of Remembrance in November to educate, you know, like the patient community about transgender issues.
Wonderful. Well, I think at this time I need to wrap us up here. I see a comment from Lisa Smith in the chat room. I've included links to the LGBT guide that Cecilia just mentioned from the Joint Commission, and also the Center of Excellence for Transgender Health. And then also Cecilia's organization, transgenderlawcenter.org, which has a number of resources and some help to think about a lot of these questions and concerns as you're working your way forward in your journey with your clinic. Just a couple of things to keep in mind. I'm not wasting your time here. This was Transgender Health Month. Next month, we're focusing on MSM of color. The month after that, African American Latino women, and then after that, youth. We're going to be focusing on the intersectionality of all these identities as we work our way through, and we're going to be wrapping up the end of our initiative thinking about sustaining and then spreading our goals. We have 2 office hours next month related to MSM of color stigma, one for providers as a focus group and one for consumers as a focus group. And we're really excited to continue picking at this issue of stigma, discrimination, trauma, because it certainly is a big overarching theme with all the folks that we're trying to serve and help to achieve health equity. So again, this is Michael Hager with the National Quality Center. Thank you so much for joining us today, and thank you very much for sticking with us a little bit late. We got a late start, and we had such great conversation that we couldn't bear to cut it off early. So thanks so much for all you do and for joining us, and we'll see you next time. Have a great day, everybody.
Thank you.